abduction as a result of the extensor mechanism. Sorry. Called Wartenberg's escape sign. Interosseous is too weak to keep the fifth finger adducted, so it escapes during fifth finger extension because of the extensor moving into it.
What if it's not
Sorry. I just want to make sure I'm.
I get that for ulnar.
Yeah. Yep.
It says Wartenberg sign in bold.
Wrist and hand? Okay.
It says sign in bold. It's clinical test Wartenberg sign.
And it's under wrist and hand pathology? Okay. So I'm getting to the right one.
539. Slide 40. Bring the fingers together.
I'll have to double, I'm not going to obviously double check that after practice. Wartenberg's is not on the exam, but I will make sure that I get you the answer to that so I can better differentiate it myself. Like you're saying, it's between the sign and the syndrome.
And the book, it says syndrome is for radial nerve. It's talking about the compression of radial nerve, sending the sensory feelings.
And I believe you 100%. I just want to double check it myself, and I don't want to have you having that in the back of your head.
Wartenberg sign is definitely for ulnar nerve.
The escape sign is going to be for the ulnar nerve. I want to double check why I had it listed on the radial slide for pathology. Sorry about that. That won't be on the exam. And I believe that it's 100% what you're saying, Laura. I just want to double check the references myself. All right, so we're already going through pathology. Special tests of the elbow that I'd like for you to know. Sensitivity and setup. Bicep squeeze. And that's it.
What was the first one?
Oh, if you remember from the elbow,
I just heard bicep squeeze.
quite a number of them didn't have sensitivity to
Just
special.
bicep
And the few that did, they were kind of low, so we're like looking at least a bicep.
Just the speeds, you said?
No,
Bicep squeeze.
Squeeze. All right, so healthy elbows done. Manual techniques. Again, it's going to be the consistent pattern, quality, quantity, MPL, all the things that sort of. Elbow pathology. We did capsular, non-capsular, contractile. The entrapments I told you to be aware of. I want you to really know those and nail those if you're asked the question on the exam about them. There's obviously questions about them, which one is most. I'd rather you know than very, very. And then special tests. Bicep squeeze, I definitely want you to know sensitivity and specificity for that. And then the other thing that would have been included in the special test, and I already made reference to it, is the transverse friction for the tennis elbow. Be aware of tennis elbow. We went through and we talked about tennis elbow in the pathology. There was one in particular that was more common than the others. So when you're studying things, it's always good to compare and contrast lists, or lists within lists, or things within lists. Those are always good to know. I think those are always fair game. Fair game. If they're not asked this time around, next year they'll be asked next time. And we're not going to have a cumulative final, so you won't have to worry Make sure you tell Kelly that it's cumulative though.
I will. Quick question, maybe stupid, but can you just run through all the end feels within the elbow?
Okay, it's firm,
Yeah, whether it's like firm or hard.
hard.
Yeah.
Okay. Okay. Humeral ulnar joint. Humeral ulnar joint is hard.
In both during inflection and extension.
I'm sorry?
Inflection and extension.
Yes, it's going to be hard in flexion and extension. Coronoid process and the electron process. That's a tricky one because you think this was going to be what? And is soft comfortable?
What happens when you have to
Yes. Just
corner process and
prodding you, that's not I can't spoon feed you everything.
corner process?
Caldwell said it was hard.
What?
Caldwell said it was hard.
Yeah, it is.
Oh, okay.
But he
Sorry.
made a special note to say that if it's active movement, it would be soft tissue approximation.
I could see that. And I totally get that. But then I probably wouldn't call it an end field.
Right.
Because to me, an end field is something that I would challenge the big guy. He could just pick me up and just throw me away like a nut. But I think I would kind of challenge him only in that respect. I probably wouldn't refer to it as an end field. So remember, humeral ulnar for practical, hard. Humeral radial joint. It's going to be humeral radial joint is going to be hard in pronation and firm in supination. Proximal radial ulnar joint. Again, hard in pronation, firm in supination. Just per call.
Sorry, just to backtrack. If I remember correctly, the interosseous membrane was taught in pronation, right? Or am I wrong?
Interosseous membrane.
So, I understand.
It's supination is going to be loose. Pronation is going to be tough.
Yeah.
Is that what you said?
Yeah, and I understand why it would be hard. This actually is going to be a separate thing. Like, I understand why it would be hard because the bones are crossing, but why is that then? I was confused why the interosseous membrane is taught there and not in supination. That just came to me. I'm sorry, I didn't mean to
No.
sidetrack.
No, not at all. Good question, to be honest with you. Carlton-Bourne separates it as a middle radial ulnar joint, so I think he's just really, I wish he was here to act. I think he's just assessing it based on what he's seeing for the interosseous membrane.
Okay.
I don't have any other better explanation of
Okay.
that.
Never mind, sorry then.
It's okay.
Yeah.
It's just part of what you're going to be doing for the rest of your career, talking with your colleagues, and that's an important thing. And that would be a great thing. And not to sidetrack now, but Carlton-Bourne happens to be still amongst us. I'm a big person of trying to contact the horse's mouth. So if I get a chance to email him, if he emails, then maybe I'll get an answer for him. I did that with David Butler a couple years ago, and I finally met him and thanked him for getting me back to my email. I talked to Todd Ellenbecker while I was running through the airport because I needed to know about his shoulder question. And that's just me. I like to know the answer because I hate to be a fountain of misinformation.
Thank you.
Any others? So the pronations are going to be hard and the supinations are going to be firm. That should take us through the rest of that. Okay?
Thank you.
Yeah, no problem. So again, we were moving into, went over elbow pathology. I talked about entrapments, special test, bicep squeeze, and wasn't a special test, but it was a special application during special test because of the Mills manipulation and how we got you like 60 more degrees of motion at your elbow. To know the transverse friction would precede the Mills manipulation. Now,
I had a question on the radial tunnel syndrome compression
Yes.
test.
So you said that you prefer the supination, the resisted supination, but is that going on for 60 seconds, or is it just the compression?
The resisted supination, you want to, you're going to maintain the contraction because you want to bring on the symptoms. You don't have to hold it longer than the 60 seconds. Chances are, if you're suspecting radial tunnel and it's present, it's going to come on more quickly than 60 seconds. Almost the same thing for the elbow flexion test. You have to make sure that they're in supination. You're holding for that 3 to 5 minutes, but if they start to experience their symptoms in a minute, finish the test. That's it. That's the end of the test. Just make sure that you're not doing pronation. You got to be doing supination. And we already nailed the question about rotatory instability. So, move on to wrist and hand so far? Okay. Again, healthy wrist and hand. We went over joints, the regions, the muscles. The compartments are something unique to the wrist and hand, so are you familiar with that? Know which compartments are more problematic than others if we want to match up now pathology and healthy. What are the contents of the carpal tunnel? What's the main nerve compressed in the carpal tunnel? The only nerve compressed. Again, going back to peripheral entrapment. If it shows up. I wrote like 60 or 70 questions and then I had to take some out. Because your exam's only 50 questions. Okay, even better. And Kelly, you know that the final's cumulative?
I'm already wise to it.
All right, okay.
Three different people.
That's fine. No, it is not. It is not. I may, and I hate to mention this now, but please don't put this as a priority. I may ask you to submit your charts project more towards the end of November. That way I have a chance to look it over and then give it back to you if there's a revision, so that if there's something not right, you get a chance to know that it is, and then you can fix it from there. The assignment that I gave out, 5% of your grade. Charts. We'll review it. Remind me on Tuesday to make sure that you're all on track with your chart assignment. That by now you should pretty much be able to just whip it out in like a half hour's time. Kinesiology, and then we talked about the carpals. We talked about the kinesiology, carpals, how we're moving from the fully flexed and ulnar deviated position. What happens to the distal row on proximal roll, closed packs, neutral, and then we go back, come into extension, and finally have the closed packing there. Good. We went through the manual techniques. Someone say it for me so I don't have to say it like for the 6th time today. Quality, quantity, end field, reactivity, end fields, closed pack, open pack positions, not only for just the carpal bones, but metacarpals, the IPs, the phalanges, and thumb, CMCs, because that's a little bit special versus the rest of them. Wrist and hand pathology, again, we broke it down into intra-articular, peri-articular, extra-articular, and then further more into capsular, non-capsular, and contractile. Entrapments, again, we went over. Entrapments again, so pay attention to the entrapments. These are the kind of things, when we come to entrapments in the clinic, people say, oh, I have wrist pain, I have hand pain. Oh, it's just a little numb, it's nothing. And it turns out to be something a lot larger than nothing. So that's why it's important to be familiar with those, and I want to really hold you accountable for those. And then in terms of special tests for wrist and hand, had Tinel's Phalen's that I'd like for you to know, sensitivity and specificity. And I mentioned the press test with it being very sensitive for TFCC tear compression. So I would like for you to at least know that one. Sensitivity is going to be 100, and specificity, I'm sorry, I only gave you sensitivity for that. The second number I gave you was 79%, and that's when they look at TFCC tears with an MRI.